Hi guys, it's Dr. McJunkin and
Tara Barron, physical therapist.
Dr. Tara. Yes. So today we are coming to you live and we are going to talk about pelvic physical therapy. So I'm excited to talk to Tara, and she is truly an expert in this space, and this is all that she does. So we're going to, if you guys have any questions, feel free to ask those questions. I have a few of my own. I will start just with some simple stuff. Tara, why don't you tell us about, how you got into physical therapy,
Okay.
and then even how you got in, how you specialize in pelvic physical therapy.
Okay, so I got into physical therapy. Actually, for years I wanted to be an OBGYN, and I decided at some point during
And is your dad
an OBGYN,
Yeah,
a perinatalogist, so
Yeah.
high-risk pregnancy doctor. So I always thought that's what I was going to be. I just love the idea, bringing babies into the world. And then something shifted end of college, and I decided to go find myself in New Zealand. And then I came back, and I was gonna either go to med school, or I ended up loving PT stuff. So I ended up going, working at a place that I was a tech, and I loved it.
in New Zealand?
No, came
Okay.
back to the States, and then I was a tech somewhere, and I just really loved it because I never had to sit down. I could spend lots of time with patients, and I could help them. You could see results pretty quickly. So I was like, I really like this.
Yeah.
So this is what I ended up deciding to do. And then I was in PT school, and I was kind of like, it's kind of boring, that shoulder. I don't really like the shoulder, or like. Yeah, ankle, hip, but
Yeah.
just certain things I was like, not that exciting. And then there was a women's and men's course, and I was like, oh my goodness, this is amazing. And so I loved it, and it was easy. Like, I didn't have to study for it because it just was it was just so easy. It's like came to me so easily. So I thought, oh my gosh, this is what I love.
Which I know just because I've talked to other physical therapists.
Yeah.
That's the opposite of what most physical therapists say, right?
Yes, they're always like, that looks scary.
Yeah.
That doesn't make sense. I'm not sure I want to work with that.
So for you, it was just like, this is awesome. I love it. It was like more intuitive.
Yes.
Like you kind of found your calling?
Yes,
or?
that's
Okay.
exactly.
Okay.
And so I started doing more of that. And when I was in PT school, I decided to go and do there's classes you take after to do a lot of the women's and men's health.
Mm-hmm.
And so I did that during school. And at the time, they didn't really take students, but I said, hey, this is what I want to do. So please let me in. I'm very mature. I promise I will be good in these courses, because it's usually people who are already had their doctorates. So I did it and absolutely loved it. And then, interesting enough, I ended up getting some pelvic pain.
Oh,
So,
I saw that on your website.
Yeah. So I ended up getting pelvic pain, and I ended up being a patient as well as the therapist.
Can I ask, do you know why you got pelvic pain? Or
Yeah. I ended up getting a bladder infection,
Okay.
and for whatever reason, my body and my muscles down there spasmed up with inflammation
Got it, okay.
and irritation.
Yes.
And so I ended up being a patient,
Okay.
right, during that time. And so I think that's what really gave me that passion, that empathy for patients, because I was going through the same thing. So it wasn't fun, but I learned a lot, and then I felt like I could help patients because I had been in that same same issue, same thing, going through the same stuff. So.
And then, so that's awesome. So that's great. And I think, I love the fact that this is, a calling for you, and really like a specialized niche. Tell us just a little bit about your practice. Like what, first, where is your practice? I think a lot of these people, my practice is in Phoenix, actually real close to you.
Yeah, right down the street. Yeah.
So tell us about your practice, though, because some people are watching maybe from Arizona and some people not. So
okay, so or just down actually the street from you, just at Tatum and Shea in Scottsdale, Arizona. And my practice, we have a couple. It's more of a I like to say a little spa environment, but it's separate rooms. Obviously, it's very private, and a couple therapists who work on just that pelvic region. So you go in, have soothing music on, and then we are each in a room, so you feel really comfortable, and it's private. And so we work with a patient for the full hour. So a lot of places, might do 15, 20 minutes with the patients, but we spend that full hour with that patient doing anything from manual work to stretching to certain kind of exercises, just depending on what their diagnosis
really
is.
Personalized, it sounds like. I've been in your practice, and it's definitely like a spa and really nice and chill environment.
Yes.
Yeah, it's really Which is, a sensitive subject for a lot of people.
Yeah, and most people coming in are very nervous. So that's one of our things, is trying to, calm and make it feel really comfortable.
Sure.
And something that it's like, hey, everyone deals with this. You're not the only one, even though it feels like you are, because you don't usually talk to your friends about these more intimate areas. So we try to make sure you feel really comfortable and that we're really knowledgeable and confident that we can help you.
Yeah.
Yeah.
And then what's the name of your practice?
So Desert Physical Therapy and Pelvic Health.
Okay.
Yeah.
Yep. So it's a wonderful facility, and if you guys are struggling with any of the issues that we're going to talk about, I would certainly recommend Tara, and she's an expert like we mentioned. And so let's jump into that, though. What are the common kinds of patients that you typically will see, or what are the common conditions, I guess you might say?
So we get from females, it can be incontinence. This can be from right after having children. It could be as an athlete. They sometimes have incontinence for just various reasons. Then sometimes we'll have it with menopausal women. We'll get that. Mm-hmm. Men, it will be post-prostatectomy issues, or just as they get older, there's a weakness in the pelvic floor for a lot of men, or a removal of a prostate. And so they have one less sphincter to help support, and we just make sure we strengthen that. I
noticed that on your website, so that after surgery for men, the post-prostatectomy is kind of like a big, sounds like a point where men start to have more issues.
Yeah, they have lots of incontinence and ED issues, but incontinence is the big one. And so we get a lot of men coming in.
It's interesting because I've thought more of that along the lines of oftentimes being like a nerve issue, but obviously the nerves and the muscles are connected, and are you primarily dealing with the muscles, or kind of retraining the muscles and nerves?
Retraining the muscles, helping strengthen them if they're weak, right? If they're too tight, then helping relax them. And then nerves, if the muscle's in spasm, then we try to release those muscles to allow that nerve to heal and get that oxygen and blood flow, right? Because it gets really mad when it doesn't have that.
So then let's, so I think that's a really good overview. Let's kind of dive into, first we'll talk about the women.
Okay, yeah.
And then we'll talk maybe more about some of those men things. But women, so, you mentioned all sorts of, and, on your website, I know that you specialize in people with pelvic pain.
Yes, yeah.
Spasms, incontinence,
prolapse,
so all sorts of different conditions that someone might. What's the most common thing that you see?
That's a good question. I would say incontinence, prolapse. I know it's all the same, and then lots of pelvic pain. So so those three.
Did they go together? Is that the same person? Like they have all three of those?
No, usually it's very different. Incontinence is separate, and we do separate things for incontinence issues. Versus prolapse can be weakness or tension. Okay. And then pelvic pain is usually mostly always some sort of spasm through that pelvic floor or through the pelvic girdle. Okay. So
Well, let's talk about incontinence first. And so generally, I like to think about, and certainly I'd love to hear what you think, but I like to think about stress incontinence and urgency incontinence as kind of like two separate things.
Yes.
Although I know some people have what we call mixed, a little bit of both.
Right.
Do you think of those as two different things, or are you attacking that person who has incontinence in a similar fashion?
Usually different. So, the stress incontinence, usually there's a weakness in the pelvic floor, or there's intra-abdominal pressure that changes, that pushes down a lot. And so we make sure we work on strengthening and then sort of rebalancing that whole area through the abdominal wall, so they're not putting pressure straight down into that pelvic floor. With urge, a lot of times there's a lot of distraction techniques. There's more of a learning how to contract or behavioral changes that we do a lot with urge.
So then, is that called behavioral therapy?
No, well, I mean, I guess not technically. It's just it's like lifestyle changes. It's like you, urge, say you're going somewhere and you notice every time you go to Home Depot that you all of a sudden leak, right? And we got this urge. So now we know you have a trigger. So we teach how to kind of switch that trigger, to lessen that trigger, and other options to try to change that, because your brain and your bladder now are talking. Right? They're like just chatting away, right? Yeah. And we want them to be a little separated, because now they have this pattern. And so we want to decrease that patterning. And so we have techniques that we do to decrease that pattern.
To kind of break that up.
Exactly.
Okay.
And sometimes the urge will also be pelvic floor spasms.
Right.
So some of the
muscles. We've had a lot of people who've commented about pelvic floor spasms. I think it's obvious for most people what incontinence is.
Right.
But how would someone experience? What are they feeling when they have pelvic floor spasms?
how are you diagnosing that? How are you treating that?
Right. So a lot of times patients will come in and they'll talk about like burning at the urethra, burning at the opening of the vagina, burning for men at the tip of the penis, or just through the scrotum, or to the, into the underneath in the pelvic floor. Mm-hmm. So they'll come in with different sensations, right? I have always an urge to pee, or I have burning, or when I sit, it aches down there. Okay. There's pain all down there. And
so are you thinking of that as like, there's something we think of as called like referred pain. So like, you know, like if your liver hurt, you might feel pain in your shoulder. Is that something similar or not?
So it can be. So some of, right, if you feel like, if we're talking back urge, right, or the bladder, you're always feeling the bladder. So a lot of patients probably of yours is like, I always feel like my bladder. I've never felt my bladder before, and now it's like I'm aware of it all the time.
Yeah.
So sometimes it's the pelvic floor that's causing the irritation to the bladder. Because if you think bladder and the pelvic floor, and if it's really tight, that bladder tries to expand, and as it tries to expand, that pelvic floor contracts. Now the bladder contracts, and so you're feeling your bladder all the time. So releasing, so the bladder is referring pain in, the pelvic floor is referring pain into the bladder, essentially,
yeah,
right?
That makes sense.
And so if we release the pelvic floor, that bladder now gets that chance to expand and doesn't get angry and feel like it has to go all the time. So that's one of the things.
Most of the time when I'm thinking of physical therapy, and this probably is not fully accurate, but I'm thinking of strengthening muscles, but really, you're talking about maybe relaxing and strengthening, probably, right?
Yeah, so sometimes we start, depending on what's going on with them, releasing those muscles, relaxing the muscles, teaching how to relax those muscles, and then we can reprogram them and start to strengthen. So, because sometimes there might be where people are holding their stomach in all the time and their pelvic floor now gets tight. So we have to teach like, hey, what are you doing that might be contributing? Why is that pelvic floor tightening all the time? So it might not just be the pelvic floor itself. It might be surrounding butt muscles, right? Abdominal muscles. And someone might be a butt clencher or a tummy clencher, right? And so we have to teach releasing that. And a lot of times that can help relax the pelvic floor.
The other thing I saw, and so maybe this isn't the perfect segue, but I saw, and I just know that there's sometimes psychological overlay on some. So I think pelvic pain is known to have a real psychological overlap.
Yeah.
Do you see that, and so I guess the reason I'm asking is so you're talking about clenching, and I'm just wondering about like anxiety or something like that.
Yeah. So what I always tell my patients when they come in is like, in my almost 20 years of practice, I have never seen, a surfer dude come in and is like, hey, what's going on? I'm so relaxed. Nothing bothers me. I always get most people in there that have a little more tension, type A, or just like anxiety, a lot of stress, which pretty much most of us have. Like you don't meet many server dudes just totally relaxed. So a lot of that body, right, that nervous system. So most people's nervous system is revved up. And so there's also where we have to do a lot of calming techniques, breathing techniques. Sometimes we refer out to therapists to teach how to do a lot of that relaxation for the nervous system. We do a bunch of that too, but because a lot of it is just that body. So you think of pelvic floor tensioning, it's like people who get migraines or like neck pain or low back pain from stress. It's the same thing. It just happens to go to the pelvic floor. And I always say, I'm sorry guys, your stress just goes to your pelvic floor.
That's interesting because I think I really do think of the neck, like you mentioned.
Yeah, like this,
that,
right?
Headaches. Yeah, people like, I'm so tense.
Same thing in the pelvic floor.
Oh, that's interesting.
Yeah,
okay, because I don't know if I've thought, and so there are just certain people. Yeah. And for whatever reason, they're predisposed where their attention's going to go to their pelvic floor.
Yeah, we don't know exactly
Does that happen even when they're young? Or is it something?
Yes. We start to notice that. So I do have some like teenagers or something and clenching, and they don't know why they clench there. Like, I don't know why I clench there. So some will notice this is their pattern, and it could have been they've had UTIs when they were younger, and so anytime there's any pain in the rest of the body, just like the UTIs, they would just clench. And so they're nervous, and it's like, oh, we need to protect. Let's clench here. We're going to give yourself a tight hug.
Yeah.
And so it doesn't know how to unhug, right? That tight hug because it wants to protect.
Yeah.
So I always say the body is there trying to protect. It's just doing too much of protection. And we are trying to teach it to say, hey, everything's okay. Yeah. Let's get back to what's normal.
Got it. Okay. That's interesting.
Yeah.
And then I think you mentioned, hypoxia or not having enough oxygen to an area.
Yeah.
Which I think is really interesting because I think a lot of diseases basically are inflammatory in origins, and sometimes that comes from hypoxia.
Yeah.
How much of the pelvic floor, let's say, dysfunction,
Yeah.
Do you think comes from those kind of two things, or are they all connected?
I think they're all connected. Sometimes, right, if a nerve's irritated, the pelvic floor spasms and then causes more nerve irritation, and then they're both like, on each other. Sometimes that pelvic floor through years start to tense up, and that nerves get irritated and they don't get that breathing room, and so they start causing burning, aching, right, sharp pains. And so I think it can be a combination, right?
Okay.
So it's always hard, but like, especially with any sort of surgeries, trauma, infections, sometimes that nerve gets irritated, the pelvic floor responds to it. And then as the nerve starts to relax or, heals a bit, then what ends up happening is sometimes the pelvic floor doesn't remember how to relax. And so that's where we come in to kind of reprogram, like help it.
Yes.
Right?
And then, so that's kind of interesting. So yeah, I totally can see that, and that makes a lot of sense. I'm glad you explained that.
Yeah.
So then we kind of talked a little bit so far about incontinence and maybe the couple different kinds. We talked about spasms.
Yeah.
Is there another common condition that women in particular have, or are those kind of big ones?
Yeah, that's what we see a lot. We also see postpartum stuff too, just like anything
leaking. I was saying weakened.
Yeah,
I want to say weakened, not
leaking.
Yeah.
Weakened and leaking, pelvic floor, leaking urine from the pelvic floor. Also, a separation of the abdominals. We'll see that a lot with postpartum. But I would say, like, I see a lot of the complex pelvic pain patients. So that's just a lot of like kind of everything: bladder issues, rectal issues, constipation. We see a lot of people with constipation that can be from a lot of pelvic floor or a lot of tensioning through the abdominal wall. So we see a lot of that too, because I think with just diets and changes, a lot of constipation issues, and then it irritates bladder, right?
Yeah.
And pelvic floor, and then going to the restroom, right? So there's a lot of things that come with that. So incontinence, prolapse, pelvic pain, right?
One of the things, so, I've done some research on some neurological conditions like Parkinson's.
Oh, yeah.
And so they really, one of the biggest presenting symptoms is constipation. But they have like a slow transit in their gut because their sympathetic and our autonomic system's kind of dysregulated. Have you noticed anything with neurological conditions and pelvic floor dysfunction?
There is. Interesting enough, we don't see as many with that. It's a lot less. I don't know if we just don't get referred as much to those patients. So every so often we'll get some patients with that.
Yeah.
So there will be issues with different people who have really laxity of their connective tissue that will have more issues down in the pelvic floor and urinary and bowel stuff. Like spinal cord injuries.
Yeah,
we'll get some of that too, right? So I've had a patient with Parkinson, and so yes, there was a lot. He ended up having a lot of pain issues, but then constipation and a lot of rectal pain from that. So we'll see that as well.
It seemed like those people would actually have a lot, but they might be dealing with other
Yes, and
conditions.
I think that's probably like but we'd love to see them. We just don't see as many. We just don't get as referred as much. But that might be another kind of niche to bring in to help them, because I know they go through a lot with down there.
Yeah, I think a lot of times have bladder and bowel problems as well. Yeah. Okay, so that's fascinating. So far we've talked about, mostly I guess talked about women.
Yeah.
Is there, and some of the, maybe I would say, postpartum kind of issues that are maybe slightly different.
Yeah.
And then some of those other ones I would imagine trend towards an aging demographic. Is that true?
Yeah, so we'll get pre and post menopausal issues too. So that comes with bladder stuff too.
Yeah,
right?
so tell me about that. So that's really interesting, like the hormonal effects on how these muscles work in conjunction.
So if you think about, like I always say to a lot of my women is, right, you've got these plump tissues and muscles are nice and bulky. As that estrogen there's less and less, the actual tissue inside gets tighter, and the muscles usually atrophy a bit, and then they get tighter. So some women will end up having a lot of leakage, and it may not be from weakness, it may be just because everything's so tight and pulling away, and so they'll get leakage or they'll get urge stuff. And so sometimes a wonderful some sort of estrogen cream works really well, and then releasing those muscles, getting more extensibility through those muscles actually gives more blood flow to them. And then so many women do so much better with that combination. So
what do you think the hormones do? So do they, like if you do estrogen replacement, is that increasing, you said the plumpness?
Yeah,
is that
it's kind of like, it gives a little plumpness to the tissues, right? And then if you think about where the urethra is, you got a lot of tissue that helps support that urethra. And so when things start to decrease and get thinner, then it moves away. And so then you have more laxity in that urethra. And so there's more, right, incontinence, more leakage. And then when you get a little more plumped up, or if we do a lot of therapy between releasing or strengthening, that gives more support, less leakage, right?
Can you,
and
so
less
you brought a model.
Yeah.
And I think it'd be fun just to show us.
Yeah, all the muscles.
Try and orient us towards, you know.
All right, let's see if I can.
Yeah, this is tricky.
Okay, we're in a small space here. Okay, so here is the pelvis. So if we're sitting right here, then you've come into that pelvic floor through here. You can actually see all these muscles. I just have this disconnected for a second, but you can see all these muscles that kind of play a role in supporting through that pelvic floor and through the organs. You can come in and take another layer off, and then we have the deep pelvic floor called the layer 3 muscles that help also support the bladder and the rectum. And then it kind of supports everything here, keeps you continent. So these muscles that we would work on between these superficial ones and then these deeper ones, we'd work on to strengthen and to plump up, or, you know, especially for incontinence issues. Obviously, if you're having pain with intercourse or pain outside, we a lot of times do more releasing. And it depends on like age group. If there's someone who's going through more of the changes through going through menopause, you know, we always ask that they usually supplement with something if that's okay in their care and their medical history. So we work on all these muscles. So we do a lot of internal work, which usually when people come in, they're like, wait, what? So they're thinking PT, physical therapy, I'm in a gym and I'm like, you know, lifting weights. But when they come in, we do a lot of manual work through that pelvic floor. We do a lot of internal and we do a lot of external stuff.
And so you described this to me. And I think, you know, everyone who we came and had lunch with you and we were all kind of like, whoa, internal work. So tell us what that means exactly.
So internal work is we have a gloved finger and we put internally into the muscles. And I always say to patients when they always say, Tara, I don't really think that's great. I said, this is one of the only muscles that you can get from one side and you can get to the other side. You can't do that on your bicep. You can't do your quad. So we can get on both sides to help release it, I think, just much more effectively, right?
Sure.
So when we go internally, there's a lot of techniques we do to release those muscles, to relax them. And I always try to make it really comfortable with patients because it is kind of a weird, we're like, this is kind of weird, but I always say...
There's something called like active release technique. Is that the same kind of idea?
You could do active release. There's called trigger point releasing or ischemic pressure to release the muscle. There's different like Thiel's massage. There's a lot of different little things you can do in there. Lymphatic massage. To release those muscles to feel so much better.
In a female, just to be clear here, we're talking about having like a finger inside either the vagina or rectum.
The rectum. Because sometimes why we do rectal stuff is either constipation or painful bowel movements or even urgency.
And so then you're getting everything just through the rectum?
Yes, exactly.
And then obviously you're doing some external work too.
Yes, so a lot of times we'll do it in position like here or it's side lying and we'll release through here because sometimes actually if you look here you got your tailbone and so a lot of people might say, I hurt my tailbone 20 years ago and then all of a sudden that tailbone starts flaring up. But sometimes when that's tight, these muscles get tight and these muscles can cause more constipation issues, right? Yeah. And these muscles through here can cause more urgency, right? Where it feels like you have to go all the time. Yeah. And these are what we release. So we can work on those vaginally or rectally. So it's just different and everyone's a little different. So our treatments are never the same for each person,
it's
right?
kind of tailored to whatever
to what's going on.
And I think that's really common. Like I know my sister, when she had birth, I think she had some tailbone injury and pain for a long time afterwards. Yeah, so she would have been better. I think eventually it went away, but I think
sometimes it does. And then for some reason, I don't know why, I think there's a shift in hormones with women, but like 20, 30 years later, somehow they start getting tailbone pain or something. And it's just, the muscles tightened up, but they just weren't tight enough to feel anything. And then all of a sudden, as things shift and change.
She may have got therapy. I don't know. I didn't ask her.
Yeah, you probably didn't ask her. But but so that's what we do a lot of stuff in the pelvis. We obviously do sometimes in the glutes, right? There's deep hip rotators that play a role in sort of bladder sensation. So it's one of these muscles is called your obturator internus. And that sometimes we know can really cause some urgency frequency issues.
Okay.
So we like to work on that muscle a lot to help relax, because for some reason it loves to wake up that bladder. And sort of some of the muscles in the glutes can also refer, like we talked about, referring into bladder sensation. So sometimes releasing those relaxes the whole
so
area.
if you have really tight back or glutes, because a lot of people with back pain really have tight glutes, right?
Yes, and then that means a lot of times they'll actually have some pelvic floor issues, right? And they don't realize it until they start noticing, oh yeah, it's harder to have a bowel movement, or when I urinate, I have to push, right?
Yeah.
Or I'm going, and then when I get up, I have some dribble.
Yeah.
So those all tell us that there's some pelvic floor issues going on that we address.
Yeah, and I feel like I hear those complaints frequently, like those exact things.
Yeah.
Now, a question I have, and this is maybe more technical. You talked about the level 3 layers, layer 3 of muscles.
So those,
and you said those are generally maybe more responsible for incontinence type issues?
Well, I would say both of them between these layers and these layers. Sometimes the urgency sensation will be more the deeper layer, these ones. Yeah. So it can be, everyone's a little different. So I shouldn't probably do that as a blanket statement. But yeah, it can be these ones, it could be superficial.
So if someone's having spasms and pain, that could also be in these exact same muscles.
Yeah, so there's quite a few. There's 3 layers, and there's all these different muscles in those layers, just to kind of make it easier. And they all kind of refer or cause different sorts of pain. Some of them overlap. Some of them, it's like, oh, we know that one's usually the culprit for, like obturator internus. Even though it's not a pelvic floor muscle, it does do a lot of issues with urgency frequency.
So one of the things I would imagine doing what you do is you probably see a lot of people who've seen all sorts of other doctors, specialists, therapists. And like maybe you're like the first one, they're like, oh my gosh, you figured out what's wrong with me.
Right, yeah.
Tell me about that a little bit. Like, do you have anyone who comes to mind, or is that, I would imagine that's like a common thing.
It is a common, because I think, this is it's not a new field, but like there's not always addressed, right? And it's not
very
something
specialized,
right. Yes.
Right?
So a lot of people, when they come in, they'll talk about their stuff, and then I'll ask certain questions. They're like, that's so weird that you know that. How do you know that? And it's like through the years, this is there's a pattern. A lot of patients have these things, and we validate what's going on with them. Like, yeah, we know you have this. This isn't in your head, right? Like there's something going on, right? And so,
which that's got to be probably really great for people.
Yes, I always say, people say, I feel hopeful, Tara. Like, this is the first time someone's listened to me, because what we do too is we have an hour and a half for our eval. So we get to sit down, and I always start with like, tell me your story. Tell me what's going on. Tell me what you've, asked that no one's really answered, or like you want to tell your story. So we can help you.
This is just curiosity, but how often is there a scenario where they have like traumatic events in their life? Like you hear about those things that rear their, like, a death of a loved one, or a divorce, some traumatic event that had occurred, and now all of a sudden it rears its head as this. Do you see that kind of thing?
Yeah, we do. It's all across the board, right? I even had a patient, she goes, it's weird. I realized when this all started, her cat passed away, or a family member, something happened, or there was a stressful event, or there was some trauma. So we see that a lot with how the pelvic floor clenches, or kind of, it's always like that protection. That's what I think. And I always tell them, your body's doing a great job protecting you, but that's not what you need right now, right? It thought it was helping you, but it actually is irritating you. So we just have to tell it, like, hey, just chill out, and we're going to relax you and release you. And then it helps a lot. And we have, in the session, we talk, and we try to make everything really calm, and like, this is normal. Everyone gets this done. Because I always say to patients, I know you feel like you're the only one getting this treatment, but there's millions of people that have these issues, and there's probably more, but they just don't know. Either the doctor they don't tell the doctors most likely what happens, or some doctors don't know how to refer to us because they don't know about us. So that's what's happening.
That seems, in my mind, a little different than a traditional physical therapist. The fact that you're doing almost some counseling at the same time. Is that right or not?
Yeah, actually, a lot of my patients are like, I get a double whammy. I get my therapy, and I get my physical therapy stuff done. So
which is, and I think that that lines up more with what we know about all sorts of different conditions, that they're like the psychosomatic or whatever that. You have a physical problem, and there's mental, that there's these dual issues going on.
Yeah, and I think that happens, and a lot of patients will say, Tara, I know you know me how I am now, but I wasn't like this. I was fun. I love life. I would laugh. I wasn't angry and mad, right? And they're like, and I want to get back there. But I always say pain or dysfunction changes you, changes your life. And I said, but our goal is to get you back. And when you're laughing and you're having fun and you're like, I'm thinking about going on vacation, or I'm thinking about exercising, those are huge, because that means your nervous system's chilling out and you're coming back to life, essentially. Yeah. And that's like my goal. That makes me so happy. I always get like chills and I get so excited.
That's why you went into this. Like, that's the rewarding aspect.
Yes, exactly.
And changing someone's life.
Exactly.
Now, when you're doing, like, let's say you're setting somebody up for therapy, is it vary, or is it like, okay, we're going to start with 3 sessions and then we're going to do, or you need 12, or how does that work?
Yeah, I think well, as they always say, it depends, right? So it depends. I see a lot of chronic pain stuff, so I usually say we're gonna be buddies for a little bit, because it takes time. We only see usually a patient 1 time a week, but we see them for the hour. So it's usually, we have things for them to do. We want their body to like feel the changes and then come back. So, it depends. Like if it's incontinence, it's so hard to say, but we could say like 6 to 12 visits can be what it is. It depends on how diligent everyone's is.
Sure.
If they're not going to go home and do what they're supposed to do, well, then it's going to take longer. So I always say, like, if you put the work in, we'll see things change a little bit quicker. But if you don't, just with anything, you're not going to see.
So like normal physical therapy, a lot of times they'll work people through different muscles. And someone might be like sore afterwards, like, oh, that made me really sore. Is that the same thing here?
No, not usually, especially if we're doing strengthening through there. It doesn't usually get any soreness. You're not like, with typical PT, but with internal stuff, like if we're releasing, some people's, they might feel a little different down there, or just like a little irritation for, a little bit, or sometimes they feel so much better when they leave. So it's
like
always
if it's released, they're like, whoa, I feel...
Well, some people walk out like, I feel weird walking because they've never felt this relaxation through their pelvis.
Does it change the way that they walk, their gait, like that kind of thing?
It can. It can, yeah.
Is they like shifted forward, or what are they?
It just depends on what's going on. Years ago, I had a patient, and she was a runner, and she had some pelvic stuff after having a baby, and just pelvic pain, and we released some stuff, and we were releasing in there, and she went in for a run the next day, and she goes, I ran my fastest mile. She goes, if I could have run this in high school and college, she's like, I would have been freaking amazing. So I was like, oh my goodness. So just certain things that you do, right, relaxes. So she's in a better gait position, right? She can move a little bit better. Her hips are moving a little bit better through that stride. So, I mean, different things can happen with it. Yeah.
So another thing you mentioned is like athletes.
Yeah.
And I guess you're talking about her, but is there something to, I don't know, if you run marathons, you're more likely to have something like this, or what do you mean by athletes?
So some athletes, a lot of the athletes who do more like weightlifting stuff, but even runners, right, their pelvic floor can get really tight and they get really strong abs, but sometimes those strong abs, there's a different pressure gradient. Sometimes it presses down, and that pelvic floor can't handle all of that pressure down. So what ends up happening is some women leak. So you probably seen, a lot of people have probably seen stuff on, the news of like women lifting and then, releasing their bladder or leaking, and it became sort of a normal, but that's not normal, right? It can be common, but it's just because there is sort of something's happening when they're lifting, that they're not using certain muscles to help support that pelvic floor or the abdominal wall. So we try to help do a bunch of that stuff to help them if they're athletes and they want to not leak, because a lot of them haven't had children yet, so it's not that, right?
Right.
And they have strong muscles, but sometimes when they're too strong, they need some mobility. And if they're just like this, when the bladder contracts or is pressed down, like this doesn't have enough chance to like cause that tensioning to help support keeping that urine in. So sometimes they need more of that, range of motion or like a little bounce to it. And if they don't have that, then they can leak, and those are usually the athletes.
That makes sense.
Yeah.
All right, let's talk about men.
Okay, let's do.
So it's my suspicion is there's a lot of similarities with all the stuff you talked about so far with women.
Yeah.
But tell me, like, uniquely, you said, after someone's had a prostatectomy, oftentimes. But tell me, what are the things that you think about men maybe that are a little bit different than women?
Well, just sometimes are we talking more like bladder leakage stuff? Are we talking pain?
I guess all of the above. Yeah.
Okay. So, with men, it's a little different, especially say after prostate removal, leakage. It's their issues are a little different. It's kind of when they leak is different than when women would leak, right?
Okay.
So it might be positional changes where women it's laugh, cough, and sneeze. Men after have prostate removal, it might be from sit to stand. So I've had a lot of my men like, hey, I'm doing really well, but when I get out of the golf cart or in the golf cart, I actually leak. And he's like, and it's really embarrassing when I'm with all my guy friends.
Sure.
So we train the way to figure out what can we do to help stop that, because he might be fine. Like I could go running and no problem. Where a woman might run and that's when they leak. So theirs sometimes is very positional in different ways, or how they move or bend, causing a different kind of pressure. So we tailor it to them of what's going on with them. So we'll see a lot of just that kind of positional changes happening. So our training is a little different than the females. Yeah.
What about, so one of the things I'm thinking, because we talked about hormonal changes in women.
Yeah.
Men have a declining, testosterone, and we have some progesterone, like some other hormones also. Do those affect a man's pelvic? Like, is that something that...
we haven't seen as much with that. And that's why I always say sometimes men are a little bit easier when we're going through some of like working on things, because they don't have the shifts that women do. So it's a little bit more steady. So I haven't seen tons. I've seen men who've had to, decrease a lot of their testosterone for cancer related or something that's going on with them. And it's nothing, it's not quite the same.
It's not as profound.
Yes, it's not. So I don't see it as big of a deal compared to the females. Yeah.
One of the things that I, have done a little bit of research on is BPH and enlarged prostate for men.
Yeah.
And I've done, looked at a few different studies and it was more, I think, external massaging of the prostate, but it looked like there was some success in that.
Oh, that's good.
Is that something you typically
So
do? Or no,
I would love to do some studies on this, because I've had so many men with enlarged prostates, and we actually want a doctor in the Valley. We're going to try to do something, because we noticed when I would do, it's called a visceral mobilization, visceral organ, releasing through that prostate, my male patients would say, right, every sexual activity was better, right, urination was better, and we started to see some changes with their PSA sometimes. And so
that's interesting.
Right? Yeah. Because, there's if something is so rigid and inflamed, right, things are going to get irritated. And I think might be why. It's just a sort of a hunch. But as we release and we soften up that prostate, we start noticing changes. And so most of my men will say, like, that is such an effective treatment. So we do a lot actually working on the prostate, because that helps. And it helps so much. I had a patient, for years, he didn't want to get his prostate removed for, not leaking, and he didn't want ED issues. So we did a lot of that work in there. And he would email me, oh my gosh, I peed like I was 18 years old again, right? And he's like, and everything feels better, and my orgasm was better, in the sense of just like, because this wasn't so rigid, right? And that plays a role in all that sexual function.
So I think, from the research that I've done, the enlarged prostate relates to hypoxia and inflammation. Both two of the things that you said are made better with therapy. So that would make sense why it would benefit.
And you got that fascia in there, and you got the muscles surrounding that prostate. So we release all that. And so, that one works really well for my guys. And so he was able to wait. He wanted to wait so many years until he was 65 before he got it removed. And so, and he did such a great job. And so I think he's getting it soon. So, but he was like, if I can wait and I can still have function, and I can urinate good, and I can have sexual function, he's like, I'm happy.
That's pretty scary to have all the side effects.
Yes.
So I'm going to wrap things up in a little bit, but you mentioned fascia. And so I know there's a lot of people now talking about fascial release and all sorts of other things. What is fascia?
Yeah, so fascia, if we think about like skin, right, we've got skin underneath, we have fascia. It sort of connects to, it kind of forms muscle to the muscle. It helps connects everything. And then they're finding out, right, there's sort of a network and of like communication. Some of it, they're talking about pain fibers. Like you can sense pain faster through the connective tissue minus the C fibers, right? Which is usually our pain that we usually feel. So we notice when there's tight fascia. So if you like can move and you're like, oh, that moves really nice. And then you find a spot, you're like, oh, that's kind of painful. And so you're kind of like rolling through there. We notice when things are really tight, especially at the lower abdominal, that people have more bladder sensation or a heaviness in their pelvis, and we do a lot of fascia skin rolling in through the abdominal that helps release things. So you want that moving. It's kind of like a sweater, like it's tight here and you can see it, all this stuff pulling. It's the same kind of thing.
How much of the tightness do you think is coming from fascia versus coming from the muscles, or are they all connected?
They're all connected, so I don't know, but I always say when I do a lot of fascial work with muscle releasing, it lasts longer. So if I just do a lot of just muscle stuff, I notice it kind of wants to tighten up a lot faster because you got that fascia probably that's tight underneath there or in that area. So when we do kind of a combination, I just see such a difference with the patients. So.
And the fascial, at least the fascial work I've seen, I haven't seen it in the pelvic area, but it's like almost like scraping.
So you can do, so some of that can be scraping, right? And some of it can be like skin rolling. So it's like this, I always say like spider hands and getting through there and moving that fascia all through that body. So we've seen great results through even working on the back and the abdominal for the pelvic floor. So there's a lot that you can do along that pelvic floor. You don't do necessarily internal in there. It's too hard to do that, but through that whole area. It works really well.
Okay, so I think we'll kind of finish on this, but what would you say, like, what is advice that you think everybody should do to have a healthy, pelvic floor?
Yes.
And specifically for people who already have, let's say, bladder issues, because that's, our focus.
So one of the big things I say, and the easiest one, is one of the things that we don't do, any of us, is breathing very well, right? And so what we find out is when you're doing beautiful diaphragmatic breath, right, that expansion of that diaphragm helps with everything between intestines moving, peristalsis, the pelvic floor and the diaphragm, right? As that diaphragm descends down, that pelvic floor comes down, and they work in synergy. And so there's a nice range of motion. If you breathe really shallow, your pelvic floor doesn't do much. So it has a more tensioning just naturally. So when you do nice expansion through the rib cage and through the belly and bringing that breath up, you start to notice that pelvic floor. So that's one of our first things that we do with all patients is start to just breathe and do nice deep breathing, and that pelvic floor does that nice relaxation. And some patients, that's almost the biggest thing they have to do to feel better, right? So it can be a simple thing, is just breathing, but doing it correctly. But that's the hardest thing. And I can't tell you, majority of patients are like, I don't know how to breathe that way. I've never breathed that way. Because, we sit a lot, right? We're hunched over a little bit more, right? We just don't breathe. We're always in a stress state. So we don't get that expansion. But that's so helpful for our nervous system and our pelvic floor.
Great advice, because really we talked about hypoxia as being maybe a big underlying cause. Yeah. That would be a benefit to that.
Right, blood flow, right? You're just moving things. You got oxygen, oxygenating everything. So it is probably one of the best things to start with for patients, and it's easy. Everyone can do that without having too much. And there's so much. Do you
have a practice that you do, like a breath work or whatever that you're doing each day?
I'll do a lot of diaphragmatic breathing. I'll do sort of the box breath, right? You can do 4, right? 4, 4, 4, 4. There's another one, humming. Breathing and then humming. Humming actually gets that pelvic floor to relax. It helps with the nervous system. There's like vocal cords and almost like a diaphragm here and a diaphragm down and into your diaphragm, and then pelvic floor diaphragm. So humming is really great, and so that's sort of a nice.
Have you seen any of the research on humming and nitric oxide?
Yes, actually, I just was reading that recently, and I just had a course that I do. I was talking about that too, and how important that nitric oxide and humming was one of them.
So it's real interesting because humming is one of the things you can do to increase nitric oxide. Nitric oxide, the gentleman won like the Nobel Prize, but it relates to Viagra, Cialis, those medicines which give, I guess, erections. Yeah. But those do it by do it by increasing blood flow. Yes. Mm-hmm. And so a lot of what we've been talking about is increasing the blood flow. Right. Anyway, so that's interesting. Humming. Yeah. Do you hum each day?
I probably do more with my patients, so I don't have to do so much at home. Yeah.
You get practice.
We do, yeah. But
how about your kids? Do you teach them how to breathe or how to hum or any of that stuff or not?
Well, I try, but my kids tell me I'm just weird and I have the weirdest job ever. Okay. So, and they told me Mom, I'm sorry, but I don't think I'm going to go into your business. And I'm like, that's okay. It's not for everyone. Yeah. But I teach them breathing for when they're stressed or whatever, right?
Tara, Tara's husband is a physical therapist also.
He does all orthopedic stuff.
Yeah, and so he's more of the traditional like muscular orthopedics.
Yeah.
All that kind of stuff.
Yeah, I always say he does everything, and I do like from diaphragm down to pelvic floor. So I have this spot, and then he does everything else.
Yeah.
So yeah.
Okay, well, I think that was wonderful. Thank you so much, Tara.
Yeah,
it's really fun to learn from you, and there's a world, that I really don't understand, but you have a wealth of wisdom there, and I appreciate you sharing with us.
Yeah, well, thank you. Thanks for listening,
if there are any
guys.
questions that come up, you guys ask them, and then I'll be sure to get hold of Tara. I know she brought a few other kind of toys.
Yeah.
But I think, if you're struggling with any of these issues, I think she is the perfect person to reach out to. And thank you guys so much.
Thank
Have a
you,
wonderful
everyone.
day. Okay,
Bye.
bye-bye.